You know what needs to change. You know what's wrong. We gotta treat people the same. We gotta get along. Do you know the history of the country where you stand? Do you know how they treated the first people of the land? Do a little research. I know that it might hurt. Open up your mind, son. Then come back, we can rewrite. Do a little research. I know that it might hurt. Open up your mind, son. Then come back, we can rewrite. Come back, we can rewrite.
Thank you, Cherie, for your welcome, and I'd like to acknowledge the traditional owners. I'm going to talk over the next 10 minutes exactly about a project and more about the process of the project that we're doing in partnership with Nunanjara. So, sorry, there is a problem. These are just a summary of some of the results from previous workforce work that we've done with the NT government, looking at remote clinics across the territory. And what it showed was that there was a very high reliance on short-term staff, fly-in, fly-out staff, agency staff, mainly agency nursing staff, and an alarmingly high annual turnover rate, so 148% per annum turnover rate in those remote clinics. I guess the good news is that for Aboriginal health practitioners, the turnover rate was about half of that, but still alarmingly high, and we were able to quantify the impact of this high turnover on the effectiveness of those services, and also calculate the considerable cost of this short-term workforce and the sort of turnover that was happening. And we calculated that if the health department could halve their turnover rate, there would be savings of $32 million, which is a non-trivial amount in NT terms. So in discussion with Nunanjara about what they might be interested in doing research about, they indicated that workforce was an issue for them, and could we work with them in a similar way to do these things, to look at the impact of short-term staffing and that turnover on the the resident health teams, the longer-term staff, look at the impact on quality of services and patient satisfaction with those services, and also look at impact on cost and effectiveness. And then work with Nunanjara to look at current strategies and developing new strategies in terms of stabilising the workforce. And subsequent to this grant, we got another grant, an ARC grant, to do a similar project across other services in the territory and in Queensland. So this work became nested in this larger project going across 3 states. And what that meant was that we had a sample size where we could look at comparing NT government service turnover indicators with remote community-controlled health services across those three states, and to try and get an idea of what impact different forms of governance might have on the workforce. And then lastly, we want to develop some sort of pragmatic mechanism for services to be able to monitor their own workforce, and that ties in with the non-clinical indicators project in terms of defining a small set of indicators that are most useful for services and that can be done easily. This is the team, so we're very fortunate to have Annie and Chrissy Comerford, who's the General Manager, and Rosalie Schultz, who's a public health physician and GP on the team. That's been invaluable. And then we've got a team that's worked together for some time, multi-institutional team. It looks big, but it does reflect number one, the complexity of the research and this sort of methodological expertise that we need, both quantitative and qualitative. So, progress. The project formally started in August last year, but we've really been quite overwhelmed by the COVID and the necessity for Nundah and other services to prepare for the eventuality of COVID. And so the services understandably have prioritised that and not necessarily research. So we haven't, that's really slowed us down in terms of field work. Particularly in Western Australia, where the hard borders meant that we actually can't go and do the field work, and we are about to, or the team is about to start interviews using video rather than going to the clinics to interview staff, and we'll just have to be as flexible as possible in terms of getting out and talking to consumers. We can't really do that by video. So we've had to be flexible in that. We haven't been sitting around twiddling our thumbs, though. We've in talking to team members, and particularly Chrissy, who's a co-author on this paper, we have over that period documented some of the early successes in terms of protecting these vulnerable communities from COVID. But we've also pointed out that there are vulnerabilities not only of the residents of those communities, but there are persistent health service vulnerabilities that government needs to be aware of. So whilst there's a good news story there, I don't think we can forget that there are still problems that need to be addressed. Over that time, it's been really important to maintain communication, both formal and informal communication with the services and with Nundah, and we've kept in constant communication to see what we can do when. And I think we've both learned a lot about data. We've spent an enormous amount of time on ethics applications to 4 ethics committees in the project overall, as well as a very complex process for accessing linked data. And then we've spent quite a lot of time talking to Nundah and other services about what variables we should be looking at and how to extract those variables, and there's been a whole body of work done there. And so we've learned a lot, the research team's learned a lot about the data collection that the services undertake, and I think Nundah has learned a bit from us around research perspective on accessing data and analysing it. So that's been a positive experience over that time. What else have we learned? I think most of these things we've heard being repeated over the last couple of days and this morning. End user engagement has been absolutely critical throughout the project, from its initiation through to where we're up to now in terms of implementing the research, and will continue to be important. As researchers, we've been very sensitive to the pressures on the service and their capacity to respond to us, and we haven't been putting additional, we've tried to avoid putting additional pressure on the service. We have good research governance on this broader project, where we have the CEOs or senior staff from all the services as a steering committee that gives us direction. And just to echo what Annie said, that the long-term relationships and the time it takes to build up trust between researchers and services is very important, as is the credibility of our credibility to services. So, can we actually do the job well? And what is our track record, not only in terms of publications, but in terms of working with health services to do this sort of work? The communication, maintaining communication has been important, so we've sent out regular emails to provide progress to the services that are working with us, as well as maintained informal communication. And, in Central Australia, we know full well about the need to account for contingencies. Things happen out bush, and we need to, plan for those contingencies. COVID was a bit unpredictable, but I think we've managed that very well as well, and been able to use that time constructively.
You know who needs to go? The intervention as a whole. Stop controlling my people. We don't need your help. You know what's so messed up? Kids young as 10 locked up.